Assalamu alaikum. Good afternoon, everyone. My name is Azahra Idris. I am going to be your host today for the first session. And then I will be followed by Dr. Afnan Al-Malki. She will be your host for the second one. Today we have three lectures. The first one is going to be mitral valve repair presented by Dr. Faisal Al-Ghamdi. Followed by minimally invasive mitral valve interventions by Dr. Abdulaziz Al-Jahayim, and we'll conclude the day with outcomes of mitral valve repair by Dr. Ziad Al-Sharif. As usual, we will begin at 5 minutes past 1, inshallah, with the first lecture. So Dr. Faisal, whenever you're ready, just share your screen and we can begin at the allocated time. Dr. Faisal, you can start now.
السلام عليكم.
Do you hear me?
Yes.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Faisal Al-Ghamdi. I am a cardiac surgery resident from King Saud University Medical City. First, I would like to welcome Dr. Rakan. He's a cardiac surgery consultant, also in King Saud University Medical City. So I would like to welcome him and thank him for giving us some of his precious time.
شكرا دكتور فيصل ولي الشرف. It's my pleasure always.
Okay, so my topic today is about mitral valve repair. It's an unfortunately big topic with a small time allocated for such a topic with a lot of gray areas, but I tried my best to summarize it in a very concise and a cohesive way. So the outline of my presentation, I will first start with a simple introduction. I will talk about some of the points that my colleagues have talked about before, but we need just to recap it and so we can be on the same page and for everyone to know the terms that I will mention while explaining my points. I will also talk briefly about the mitral valve pathophysiology, whether it's regurg or stenosis. And then I will talk extensively about the mitral valve repair techniques and some of the famous techniques used to repair the mitral valve. And then we cannot talk about the mitral valve repair without talking about SAM, which is systolic anterior motion. And then I'll have a brief a couple of slides about some of the studies I have passed or read about this topic. So as an introduction, I will first talk about the surgical anatomy of the mitral valve. As most of you know, that the mitral valve is an apparatus with multiple components. It's not just the leaflets. So there is the atriovalvular junction. There are the leaflets, the anterior and posterior, and then the valve suspension system, or what is called also the subvalvular apparatus. So for the atriovalvular junction, this junction defines the hinge of the leaflet and helps locate the annulus. The annulus is located deeper and 2 millimeter external to the hinge. It's, if you can see my pointer, this is what I call the atriovalvular junction, and 2 millimeter away from this is the annulus. The annulus is a discontinuous band, as I will show you in the next slide. It is not a continuous band surrounding the whole anterior, the mitral valve. The base of the anterior leaflet, the atriovalvular junction, is reinforced by two dense fibrous structures, the anterolateral trigone and the posteromedial trigone. Maybe we can go to the next slide so it can be a little more clear to you. This is the anterior, the mitral valve from the atrial side. You can see here the bigger leaflet and the wider one, it's the anterior leaflet, and here is the posterior leaflet, which is the one with the longest circumference but with smallest area. You can see this is the annulus, and you can notice it's not a complete structure. It is deficient here and around the aortomitral curtain. And it bounds the anterior leaflet to fibrous thickening, which is the anterolateral trigone and the posteromedial trigone. And in this diagram here, you can see the atriovalvular junction, which is the leaflet hinge. And you can notice here, after this hinge, 2 millimeters from this hinge is the annulus. And it is a deeper to this structure, to this line. And it is important to know where is the annulus, because that is where your suture have to be. This is where your needle has to pass through. So to continue my previous slide, the annulus has three-dimensional saddle shape. As you can see here, it is a saddle shape with the highest point being on the middle of the anterior leaflet and the posterior leaflet, and the lowest points being on the trigone. Also, the annulus, as I said, the shape of the annulus varies throughout the cardiac cycle. Another important point, which will come later in my lecture, there is something we call the aortomitral angle. and the normal angle is 120 degrees. If it is smaller or more acute, this can predispose to SAM. So the wider the angle, the better, because when this angle is smaller, the anterior leaflet will come into the LVOT. And you can notice here the shape of the mitral valve during systole and diastole. There are two different dimensions that I will be mentioning multiple times. There is the septolateral dimension, or what the length between the septal and the lateral wall, and there is the transverse dimension. You can see here, this is the anterior mitral leaflet from a ventricular view. And this for the mitral valve is surrounded by important structures that we should keep in mind whenever we perform any procedure around the mitral valve. So there is the circumflex artery, there is the coronary sinus, there is the bundle of Hess or the conduction system, and the aortic valve cusp, mainly the non-coronary and the left coronary sinus. You can see this arrangement or the relationship here. You can see that the circumflex artery is closest to the anterolateral trigone and to the anterolateral commissure. You can see that the coronary sinus is the closest here and in the middle of the posterior leaflet. And you can see here the non-coronary and the left coronary sinus, which you can also injure if you take deep bites. For the leaflets of the surgical anatomy of the mitral valve, the anterior leaflet during diastole divides the left ventricle into two functional areas. So the anterior mitral leaflet is not only works as a door between the left atrium and the left ventricle, it also helps in dividing the flow. So when the valve opens, it creates and direct the blood toward the LVOT. So whenever there is an excess tissue or the angle that I told you about is smaller, it can obstruct this the LVOT. The posterior leaflet has 3 scallops. The largest is P2. And the scallops are more prominent in the posterior leaflet because there are indentation, but whatever areas are that are parallel or anterior to them, we just call them the same, A2 and A1 and A3. While here in the posterior, there are proper indentation between each scallop. For the surface of coaptation, this is an important point also. A normal surface of coaptation between each leaflet has to be, which is this area. This line has to be 5 to 9 millimeters to have a proper surface of coaptation. For the commissural leaflets, they work as leak sealers. They are their own leaflets, their own entities. Sometimes you have some leak here and you can apply some of the repair techniques. For the valve suspension system, the subvalvular apparatus is made up of the papillary muscle and the chordae tendineae. For the papillary muscles, there are 2 groups. There is the posteromedial and the anterolateral papillary muscles. And the blood supply of the papillary muscles differs. For the anterior anterolateral papillary muscle, they are supplied by 2 arteries, branches from the LAD and also from the circumflex artery, while the posterior medial is only supplied by the PDA, whether it is coming from the circumflex or the right coronary artery. And if you notice that the posterior medial papillary muscle is only supplied by 1 branch, and that makes it more susceptible for papillary muscle infarction. The chordae tendineae can be classified in 2 ways, either according to their attachment to the leaflets, and there are 3 types. There is the secondary, as you can see here. There is the marginal, which are attached to the margin of the anterior to the leaflet. There are the secondary leaflets, and there are the tertiary leaflets. And you can also divide them according to where they lie relative to the leaflets. So you have the commissural, which are attached to the commissure, and the paracommissural, which are surround the commissural artery. There are the main ones and the paramedial ones. For that's regarding the chordotendony. There are multiple groups of papillary muscle according to their shapes. There are 5 groups. I won't go into details, but these are the shapes that you can see. It depends on the number of heads and how they attach to the LV. I will now go to the mitral valve pathophysiology. Most of my presentation was based on a book I read for Carpentier. So for Carpentier, he thinks of the pathophysiology of a mitral valve. He divides it into three main divisions. So he will first think what is the etiology of the mitral valve disease, and this will impact the prognosis of the patient. And then he will think what is the lesion affecting the valve, and that when you recognize what are the lesions, this will impact your choice of repair strategy. And then the dysfunction, which impact also the repair technique. I will talk about them one by one. For the etiology, the mitral valve pathophysiology or whatever disease affect the mitral valve can be either primary or secondary. Primary mitral valve disease is the disease that affects mainly the leaflets and the valve itself. And there are many examples. There are congenital malformation, inflammatory disease, rheumatic diseases, degenerative like Barlow or Marfan and fibroelastic deficiency, bacterial endocarditis, especially when it causes leaflet perforation, valvular or annular calcification, trauma, or tumors on the valves. Secondary or functional diseases to the mitral valve are diseases not related to the mitral valve itself. It is related to either the LV or the LA, caused either by LA dilatation or LV dilatation. There are examples like the ischemic cardiomyopathy, dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, and other examples. And depending on your etiology, your prognosis will change. For the lesion, you have to identify the lesion in order to choose which repair strategy. So any of the etiologies mentioned before, which I have just mentioned, can cause multiple lesions to any of the valve components. So regardless of your etiology, these lesions can happen also. There can be multiple complex lesions, and the predominant lesion can mask the pathology, which also needs correction. So for the annulus, you can have dilatation, abscess, calcification. For the leaflets, you can have excess leaflet tissue or vegetation. In the commissures, you can have fusion, like a rheumatic heart disease. Papillary muscle, you can have a papillary muscle rupture, like in myocardial infarction. And for the ventricle, you can have dilatation, like in ischemic cardiomyopathy or dilated cardiomyopathy. You can have also infarction if the patient had an MI. The last thing you need to recognize is what type of dysfunction does this valve has. Carpentier has a classification for the functional classification for the dysfunction that a mitral valve has. So there are 3 types, and the third type divides into 2. The first type, but before there is a picture I will show you now, the valve dysfunction can be refined more with segmental analysis of the mitral valve. Once you recognize what dysfunction you have for the mitral valve, you can further analyze the valve by analyzing each segment, whether this P2 is prolapsed and the A2 is restricted, and so on. So the first type of Carpentier classification is whenever you have normal leaflet motion, but still you have regurg. This can happen either endocarditis with leaflet perforation, annular distension and dilated cardiomyopathy, vegetation and infective endocarditis, or if there is a tumor. The leaflet has no issue with their motion, but still there is a regurgitant flow. For type 2, it's when there is a leaflet prolapse, and it can happen with chordae rupture, myxomatous disease, papillary muscle elongation. For type 3, you have 2 types. Type 3A, which is the diastolic dysfunction, which is type 3 is restricted leaflet motion. Either it's restricted in diastole, and this is type A, which happens sometimes in rheumatic or ischemic cardiomyopathy with leaflet tethering, or during, this is during rheumatic heart disease. The one in ischemic heart disease is type 3B, which is tethering during systole, which happen in myocardial infarction or ventricular dilatation. Okay, so any questions before we move on into the main topic of the mitral valve repair, or any comments? You are welcome to add any. Dr. Rakan, if anything you need to correct or to add?
Faisal, mashallah, tabarakallah, outstanding. You know, one of the most, still, you know, you will never find elite mitral valve surgeons in the world who still understand the anatomy very well. And it's a learning process. So what you alluded to, I know anatomy for us sometimes seems to be rudimentary, and we're more interested in the pathology and the corrective techniques. But in surgery in general, but in particular, the mitral valve, you really need to have a good comprehension of the anatomy, not only the anatomy, the 3D relationship of the mitral valve to the surrounding structure. Faisal, can you just go back to the anatomy slides? Just, I want to go a few points, and you did an outstanding job. Honestly, you know, I'm still learning from the mitral valve. But again, the concept is, and all of you know this, that the mitral valve is not an entity on and of itself. It's related to the ventricle, to the left atrium, to the aortic valve, to the tricuspid valve, to the conductive system, to the coronary circulation. So you really need to get comfortable. And believe me, even if I spend a few months away from the mitral valve, sometimes I really need to go back to the textbooks and the illustrations to really drive in the anatomy again, because you really can't forget easy, because it is so complex and it's so interrelated to the other structure. So a couple of points I want to point out. You mentioned a very important point, that the mitral annulus is actually buried under the endocardium in the left atrium. So what you see, the junction, the pivotal point, or you called it, Faisal, what did you call it?
The atriovalvular junction.
Atriovalvular junction. So again, this is what you see. But as some of you who scrubbed with me, I always say, you only know you're in the annulus by the feel of your stitch. The annulus is 2 millimeters deeper than this junctional point. And this is why you need to take your bite a little bit deep, but not too deep, because if you take it too deep, you increase the risk of catching the circumflex and kinking the circumflex. So this is one important point. The other point is the relation of the mitral valve to the aortic valve. I always say the trigons, or mainly the trigons, not the commissures. The trigon are the limits of the aortomitral curtain, which extends from the nadir of the non-coronary aortic cusp to the nadir of the left coronary cusp. And this is the lateral demarcation of your aortomitral curtain. So it's very important to understand that, you know, that part of the mitral valve between the two trigon corresponds to the part between the nadir of the non-coronary to the nadir of the left coronary cusp. And as Dr. Faisal correctly said, if you take your bites too deep in the anterior mitral annulus, you increase the risk of capturing and kinking the leaflet of the left coronary cusp. So again, that needs to be carefully assessed. Lastly, as you talked about, you did not mention this, Faisal, but it's also worth mentioning because it is mentioned in the textbook, is the central fibrous body. So the central fibrous body is basically the point in the fibrous skeleton of the heart. And again, the fibrous skeleton of the heart is a collection of fibrous tissue that involves the aortic valve annulus, the mitral valve annulus, and the tricuspid annulus. And the point where the three annuli merge together, it's defined by the merger or the meeting of the right fibrous trigon with the membranous septum. This what forms the central fibrous body. The only reason it is important is because sometimes when you get an aortic root abscess, that area can be involved and it needs to be debrided. The bundle of His, the conductive system, traverses close to that area. So that needs to be understood. Faisal, just one last point also I want to point out. If you go back again to the earlier slide, You mentioned an important point about the angulation between the plane of the aortic valve and the plane of the mitral valve being 120. Now, a lot of you will see when you operate on elderly patients, you will notice one peculiar thing. The aortas are much longer and larger than when you see in younger patients. And that is because the aortic wall, like in everything in the body, ages. And the aging of the aorta not only happens in the forms of calcification and atheroma formation, but also within the wall, there is some dilatation that happens. You lose less, the amount of elastic tissue, elastin in the media decreases significantly with age. And that causes, with the constant beating and the variation impulse, the aortic wall to stretch and dilate. And the stretching and dilatation not only happens in the horizontal plane, but also happens in the longitudinal plane. So what ends up happening is the aorta elongates and pushes down on the heart. And the heart shifts its dimension from being a semi-perpendicular to a transverse position. And this causes a sigmoid septum. It's a very well-known sign in echo. When you look at the LVOT, you will find a sigmoid septum. And that is a sign that the aorta is elongated, that it's pushing the septum, causing a sigmoid shape. Now, the important if this happens is sometimes this can cause SAM. And the way to fix SAM in these cases, and it happened to me twice before. I did a mitral valve repair in an elderly patient, and I came off bypass, and there was significant SAM. And I was able to correct the SAM by tethering the aorta and shorting it, pushing the aorta more towards the arch. So taking a bunch of pleated bites, and this eliminated the SAM. So this is an important point. It's not something that you see, but it's really important to keep in mind. Faisal, go to the next slide or two slides. One more. The one we showed the papillary heads.
This one.
Yes. So again, the papillary muscle, again, as surgeons, we don't pay much attention to the papillary muscle, basically just because we don't see them very well when we're operating. We see the leaflets, we see the subvalvular apparatus. What happens deep inside the ventricles, we're not interested in because we don't see it. But it's very important, as Dr. Faisal mentioned, the blood supply. So when you get a RCA infarction, usually when you get a papillary muscle rupture, it's the posteromedial one, that one that has a sole blood supply coming from the PDA, while the anterolateral one has a dual blood supply. The other thing is the anterolateral papillary muscle is usually a solitary head. So you usually find one prominent papillary muscle with a single head and all the chordae fanning out from that head. While in the posteromedial one, you will find 2, 3, sometimes more than 3 heads of papillary muscle. So again, one distinction between the two papillary muscles. I think these are the important points I wanted to make. But again, what I advise everybody in the group, especially at this stage of your career, spend time with cardiac models to understand the 3D relationship of the mitral valve to the rest of the heart. Because again, no matter how many texts and illustrations you see, and the operating room is not prime because, again, you have limited exposure. And remember, when you're looking inside the operating room, you're looking at a flaccid heart. You're not looking at the real 3-dimensional heart when it's full and pumping with blood. So what I advise you is always, if you get the chance, go and get a cardiac model that is representative of the true D anatomy, and always familiarize yourself and ask questions inside the operating room. Because again, it's a collective of all these things that will make you understand the anatomy. And if you understand the anatomy very well, especially the 3D relationship, you will have a much easier time doing mitral valve repair. Thank you.
Thank you, Dr. Rakan. So to go back, we will start now with the mitral valve repair. It's the main topic of my presentation. I will divide it based on the dysfunction classification, functional classification of Carpentier. So first, we will just describe some of the surgical just a small summary short summary about the indication. So on mitral stenosis, the first line for treatment is percutaneous balloon valvuloplasty. It's either done for isolated moderate to severe MS or in a patient who is symptomatic and with a favorable valve. And can be also done in an isolated moderate to severe MS in a patient who is asymptomatic but with pulmonary hypertension. Contraindication to percutaneous balloon valvuloplasty is left atrial thrombus, moderate mitral regurgitation, or inadequate valve morphology. Surgery is indicated in moderate to severe MS in patients who are symptomatic, who's not fit for balloon valvuloplasty, or have failed a previous trial. On the right side, you can see the grading of mitral stenosis. You know that severe MS, and whenever the gradient is more than 10, pulmonary artery systolic pressure more than 50, and the area is less than 1. For MR, the indication for surgery are symptomatic and patients who has moderate to severe MR, or someone who's asymptomatic with severe MR, an ejection fraction of less than 60, or pulmonary hypertension. These are the class 1 indications. One important aspect for any mitral surgery is mitral valve exposure. So for mitral valve exposure, it is better to release the epicardial adhesions up to the apex, release both the SVC and the IVC if you need. Access to the atrium, there are multiple ways to access the atrium. You can go through the interatrial groove, what we call the Sundergaard groove, or through the transseptal approach, or an approach which is the biatrial approach that was created, I think, by someone who I cannot pronounce this name actually. I can show you now the pictures of the way you access the mitral valve. You can see here, just wait. This is the interatrial groove through the Sundergaard groove. You just dissect between the right atrium and the left atrium. You open with the 11 blade this groove between the left and the right. You extend your incision all the way up to the right superior pulmonary vein and downward all the way to the inferior right inferior pulmonary vein. The transseptal approach, you open the right atrium, you open through the fossa ovalis and take care not to extend your wound superiorly, so not to enter the mediastinal space. And then after that, you put some of the stay suture on the atrial septum just to retract it and put some of your retractor just to expose the mitral valve. Generally, this approach is better for patients with ischemic mitral disease because usually they don't have a large left atrial to help you expose the mitral as in this exposure. So before you embark on repairing the mitral valve, you should first analyze the mitral valve. So the aim of your analysis is to confirm or modify the preoperative echocardiographic finding, and then know the functional type of the mitral valve dysfunction. Is it a restricted leaflet or a prolapsing leaflet, or just a type 1, which is the normal leaflet with just annular dilatation or leaflet perforation. So the steps to inspect the mitral, it's good to be systemic in order to not miss anything. So first you have to inspect the left atrium and to note any thrombi or endocardial thickening or calcification or jet lesion, because sometimes when there is a mitral regurg because of a prolapsing leaflet, you can have some jet lesions or calcification around the jet area. Then examine the mitral annulus, know if it's dilated or not, know its shape, if it's circular or oval, or whether it's abnormal in shape. And then note if there is any annular calcification. Then examine the leaflet. Whenever you examine the leaflet, and I will show you a picture in the next slide, you should use two nerve hooks and do functional analysis of all the leaflet segments. I check the tissue pliability, the leaflet motion, and as I said, you have to be systemic in order not to miss anything. Whenever you assess the mitral valve leaflet, you have to choose a reference point. Usually, the reference point used is the P1 segment, the P1 scallop of the posterior leaflet, which is the least affected by any mitral valve pathology. So let me go to the next slide. You can see here, you can use two nerve hooks and then choose your reference point. Sometimes P1 is abnormal, go and look for another normal segment of the mitral valve. If all are abnormal, you have to repair one and then use it as a reference point. And then you start with the anterolateral commissural leaflet, A1, A2, and so forth until you assess the whole leaflet tissue and pliability. So to continue the mitral valve analysis, you have to expose then the subvalvular apparatus. You have assessed the left atrium, assessed now the leaflet, you go now to the subvalvular apparatus. It is necessary whenever valvular reconstruction involves one or two papillary muscle, you have to expose the subvalvular apparatus and examine it. The steps for that, you have to apply traction suture, first on the leaflet, as you can see here, around the main chordae of the anterior leaflet. The posterior leaflet is gently retracted using an atraumatic retractor. Then the head of the posterior papillary muscle is grasped and pulled upward with a Rosano forceps. The papillary muscle clamp is then used to further expose the papillary muscle. The clamp is placed laterally to the papillary muscle across the fibrous band, carefully avoiding its base. And the reason you want to avoid the base is because this is where the blood supply comes into the papillary muscle. So before we start talking about the repair techniques, there are fundamental principles of the mitral valve reconstruction. According to Carpentier, for each lesion, you have a technique to repair it. You don't have one technique that repairs multiple lesions. So you assess, you count the lesions, and for each lesion, you give it its own repair technique. The surgeon should identify all the lesions, whether primary or secondary, and then proceed to valve reconstruction. In order to restore durable normal valve function, you have to preserve and restore normal leaflet motion of the valve segments, create a large surface of leaflet coaptation. As we said, it's 5 to 9 millimeter. And the most important, and you will see it's the most consistent rule among all the repair techniques, you have to remodel and stabilize the mitral valve annulus. So I will start now with techniques that are used for type 1 dysfunction, which is what, as we said, normal leaflet motion, but there is a regurgitation either because of leaflet perforation or annular dilatation. I will mainly cover annular dilatation and mitral valve Aneuplasty. These are previous techniques used to treat such dysfunction. And the most recent and the one that we all know it works is the mitral valvular Aneuplasty. So for the mitral valve Aneuplasty, the function of the ring which we use is to restore the normal systolic relationship between the transverse diameter and the anteroposterior diameter, or the septolateral diameter. The normal shape of the annulus is ovoid, with the transverse diameter being greater than the anteroposterior diameter, as you can see here. This is a normal annulus. Carpentier has 3 disease-specific rings. I will talk about the rings in the next slide. Generally, when it comes to rings, there are 2 ways to classify them. There are the complete and the incomplete rings. And you can classify them according to their pliability. Either they are rigid or semi-rigid or flexible. According to Carpentier, he has 3 rings which fall into the same category. He has this incomplete flexible ring. He has the physio ring, which he calls classic. He has the physio ring, which is the rigid complete ring. And he has the ischemic ring. This is the semi-rigid complete ring. And he has the ischemic ring, which he used which is complete rigid ring. For each he uses depends on the pathophysiology, but these are details that differs from each ring to ring. So it's not an important thing to memorize now. You need only to know the types of ring. There are complete and incomplete, and there are the rigid, the flexible, the semi-rigid, and the rigid. So for the mitral valve Aneuplasty to continue, how do you choose your ring? As we said, it's according to the pathology. In general, what everyone agrees on for degenerative diseases, nobody agrees on a type of ring that is the best for all types of patients. But in patients who have functional MR, the best is rigid complete ring. Okay, for the sizing, I will mention how to size depending on the pathophysiology. So for the ring selection, you have to measure the size of the ring. It depends only on the measurement. It depends only on the anterior leaflet size, regardless of the ring type. All ring types use the anterior mitral leaflet to size the ring. So you have to have two measurements: the anterior mitral leaflet base and the anterior mitral leaflet height. When I say anterior mitral leaflet height, it's the distance from the annulus all the way to the margin. So in order to measure the base, and I will show you a picture now summarizing all of this, you have to place two landmark sutures at the commissure, which you can see here. You have to put, some people put these sutures at the trigone, but Carpentier mentioned that it is on the commissures. But some mentioned that you can use the trigone. So after that, you apply traction in both sutures to distend the space between them. Then the space between the two sutures, which is the intercommissural distance, is measured using the ring sizer. For each ring, there is a sizer that comes with it, and it has two notches. I will show you in the next picture where you can measure distance. Each sizer presents two notches, as I told you, which should be positioned to match the commissural sutures. Once you have measured the anterior mitral leaflet base, you measure the height. And you do that by applying traction on the marginal chordae to unfurl the anterior mitral leaflet. And the size chosen for the base measurement is then positioned to cover the entire surface of the anterior mitral leaflet. And there are three possibilities whenever you do that. And I will show you in the next picture. As I mentioned here, you can see this is the sizer. And these are the notches I mentioned to you. You use these notches to measure first the anterior mitral leaflet base, and then you use the anterior mitral leaflet height with a nerve hook, applying traction on the anterior mitral leaflet to measure the height. So, as I told you, there are three possibilities. Either both will match, the size for the base of the anterior mitral leaflet and the height will match, and then you will choose that size. Or the base will match, but the height of the leaflet, as I told you, in more than 90% of the cases, a good correlation is found between the intercommissural distance and the height of the anterior leaflet. In this case, whenever the size is matching between the height and the base, whenever it is functional mitral regurg, you choose a smaller size. So if you have an ischemic MR and the size, let's say it's 34, you go with 32. But if it is a degenerative disease, you go up with one or two sizes. So in the case if there is a discrepancy between the two sizes, as I said, you should choose the larger size. Whenever the height and the base, there is a discrepancy, you choose the larger size. That's it regarding the sizing. So to complete, whenever you measure the posterior leaflet, which is an important thing whenever to prevent SAM. It is important, as I told you, to avoid SAM, and it is not important for the sizing of the Anteuplasty ring. The measurement of each segment of the posterior mitral leaflet has to be done. And whenever the height of the posterior mitral leaflet is more than 2 centimeters or 20 millimeter, it should be reduced, because this will move the coaptation line toward anteriorly toward the LVOT. So regarding the ring implantation, it is achieved mainly by placing a series of 12 to 15 sutures. It's a 2-0 mattress suture through the mitral annulus. Two important points it has to be kept in mind when putting the ring. You have to properly place those sutures within the annulus to avoid ring dehiscence, and it has to be placed accurately into the prosthetic ring to avoid annular distortion. So first, you have to correctly identify the annulus. And this is something we have mentioned before, but sometimes the hinge line or the aortovalvular margin is not apparent. One trick you can use is to pull the anterior leaflet, as you can see on this picture, with a Rosano forceps, and move the leaflet up and down, and you can identify where is the hinge exactly, and the annulus usually is behind it. So whenever placing the sutures in the anterior annulus, the needle should penetrate the atriovalvular junction, as we said, 1 millimeter or 2 millimeter outside the hinge. And Dr. Rakan said also it is important to know the feel of the annulus, because this distance is different from one person to another. So it is good to get used to the feel of the annulus. The tip of the needle should be oriented toward the ventricle. It should be perpendicular. It should not be horizontal or it should not be also circular, because this will increase the risk of injuring any of the surrounding structure. This information we can see in the next slide, which is that the angle between the needle and the leaflet hinge should be less than 10 degrees to avoid catching a secondary chordae. See, I think with the picture, it's will be quite accurate. Here you can see in this picture, as we said, you have to go away from the hinge 1 millimeter to 2 millimeter. You have the angle between the needle. It should not go too deep. It should go parallel and 10 degrees away to not injure the secondary chordae here or catch the secondary chordae in your suture. And between your entry and exit point, it should be all in the annulus and 1 millimeter at least apart. Okay. So placing the suture in the posterior annulus follows the same, but your bite has to be deeper. As we said, in this area, there is an area where the annulus is deficient, and it is a little bit further from the hinge point. Your bite distance should be not more than 1 centimeter. The distance between each horizontal mattress should be 2 to 3 millimeter. And you can see it here between each bite, and your bite should not be more than more than or at least 1 centimeter. It should not be very small. And the distance between each bite is 2 to 3. You should never go through the same hole. So when implanting the ring, you can see the picture here and how the proximity of the circumflex artery near the anterolateral commissure. So the anterolateral commissure, you have to remember to orient the needle toward the ventricle, and you should not take it in a circular fashion or follow the needle curvature, because you might either occlude the coronary artery or put some traction on it, which can also occlude it. This picture only just to remind you of the adjacent structures. So whenever you are placing the suture through the ring, first you have to identify the sutures of the following 4 landmarks. You have to identify 4 landmarks before putting the sutures inside the annuloplasty ring. The midline of the anterior leaflet and the posterior leaflet and the posterior commissures. And you can see in this picture, he placed different color sutures, so he cannot mix up with the other sutures. And here, these are the anterolateral and the middle point of the posterior leaflet and the middle point of the anterior leaflet. So whenever you are placing the suture within the ring, you have to place it in the corresponding position of the ring. You have also to identify the midline of the posterior leaflet with the midline of the posterior aspect of the ring. So whenever there is an asymmetrical dilatation, you will not be confused and the ring will be placed properly. So on the anterior annulus side, place the suture evenly and equally in their corresponding part of the ring, while on the posterior annulus side, align the posterior midpoint of the ring, as I told you, with the P2, midline of the P2. The space between the suture should be reduced on the ring when you do it doing the posterior annulus suture. In patients with asymmetrical dilated annulus, more sutures are placed in the annulus and the spacing on the ring is reduced more. So when there is, like in this picture, there is an asymmetrical dilatation, your bites here should be big, but on the ring should be smaller in order to, to retract the annulus and make it smaller and more symmetrical. If the sutures overlap, their placement on the ring should be similar, as you see in this picture. So if your sutures overlap on the annulus, should also overlap on the ring. You shouldn't do like this. After you place your annuloplasty ring, you do the saline test, and the valve should always be testing before tying the suture of the ring, because in case there is still a regurg, or the ring was either too small or too big, you can take it out and place another one or just replace. So how to do the saline test? While the aorta is clamped and the aortic vent is on, you put a 250 milliliter of saline into the LV just to de-air the LV. Once you do that, you clamp the aortic vent while the aorta is clamped, and then you inject into the ventricle with high pressure with the bulb syringe, and then assess the morphology and the competency of the mitral valve. So whenever you do the saline test, you have to assess the height of the surface of the coaptation. So your coaptation line should not go higher than the annulus. And the morphology and position of the closure line. So your closure line should be like a smile, and it should go toward the posterior annulus. Whenever your line is near the anterior or the LVOT, this will increase your risk of SAM. So a line of closure parallel and proximal to the posterior leaflet attachment signifies a satisfactory valve reconstruction. The ratio between the visible atrial area of the anterior leaflet and the visible area of the posterior leaflet should be 3:1, as you can see here, which is the normal ratio for the surface area. A line of closure near the LVOT, which is I have mentioned, indicate excessive height of the posterior leaflet, which is one option. You can see here in picture A, or excessive traction on the anterior leaflet, which is B here, thus increasing the risk of SAM. An asymmetrical line of closure, even in the absence of leak, would be unsatisfactory, since it would indicate a persistent localized prolapse or restricted leaflet motion. So you should never be satisfied with a line of coaptation like this, even if the saline test is negative. You should look for the reason and correct it. So these are situations where your coaptation line is abnormal. As we said in A, your posterior leaflet is too high, so you will just resect part of it, and then you will just suture it and make it smaller, moving your coaptation line toward the posterior leaflet. Here you can see that there is an excessive tissue of the anterior mitral leaflet. You will do the same just to reduce its height. Here, if you have a prolapsing segment, you will just do a triangular resection, which is something I will talk about in the next few slides, in order to treat a prolapsing segment. In my slides, I chose not to put videos, fearing that it might affect my connection. So these are two videos I found on the YouTube for ring annuloplasty, ring plantation, either using the intercommissural or intertrigonal measurement. If you want, you can watch them at your leisure. You can screenshot the screen capture the screen and watch it on your own time. Before I move to type 2 dysfunction for the anterior mitral leaflet, does anyone have any comment or any questions? Dr. Rakan, you want to add anything or correct?
Yeah, one thing, Yani, in mitral valve surgery, the rule number one is you really have to have a good understanding of the 3D dimensional anatomy. The second thing in mitral valve surgery, before you delve in on the techniques of leaflet repair, this and that, depending on the pathology, is exposure. This is fundamental. Mitral valve surgery is about exposure, and it's all about exposure. Unfortunately, exposure is a practical and a technical thing. You really can't explain it much on theoretical slides. So what I advise our colleagues in the group is really spend time with the surgeons, with your mitral surgeons, and identify how each and every surgeon exposes the mitral valve. Now we're in the era of minimal invasive mitral surgery and robotic. Exposure is less of an issue because, again, you open directly on top of the mitral. So you get superb exposure, but still, you won't have robotics and minimal invasive access in all centers that you're practicing. So really learn how to get proper mitral exposure. So this is a fundamental key. And I remember asking in the board exam questions like, tell me the first 100 steps to have a better exposure of the mitral. So this is one point. Second point is, I know, Faisal, you relied heavily on Alan Carpentier's book.
Yes.
Everybody's hearing me?
Yeah, Dr. Will, I hear you.
Doctor, can you please, there is somebody who's opening the mic, please. We cannot understand you well. Dr. Akhrud, can you mute your mic, please? Thank you. خلاص.
So the second point, Alan Carpentier's technique. Now, Alan Carpentier is credited not only for describing the technique of mitral valve repair, but the first bioprosthetic tissue valve was developed by Alan Carpentier and his wife. So, who's a chemist, who happens to be a chemist. So the guy is really well versed, and you know, through him in the 1970s, we learned a lot about techniques and how to repair rheumatic and mitral valve disease. But things, as everything in the world, evolves with time. And most of the world have now moved beyond the classical Carpentier techniques. So a lot of the techniques described in the book don't necessarily apply in modern life. For example, in the area of robotic and minimal access surgery, we're relying very heavily on neocords rather than leaflet resection. So there's a lot of respect for the leaflets rather than resect. Last point I want to point out is sizing, whether it's for the band or for a ring. Is it rigid, semi-rigid, flexible? All of these are not very well versed into science. It's all anecdotal. Surgeons have different preferences. It's like, you know, different styles in closing. And every surgeon has their own way and their own style. My advice to our colleagues is develop your own style. And not only because just by style, have some rationale why you would use this or that. Take me, for example, I use rigid or semi-rigid rings in functional mitral repair. So to reduce the septolateral dimension in ischemic MR. And usually I don't size. It's either a size 26 or a 28 millimeter ring. For myxomatous or degenerative mitral valve, I use bands exclusively. And I usually use bands between sizes 30 to 32. And I don't size. I only just by eye inspection. And there are some surgeons who will use a 26 millimeter band on all of his mitrals. So again, you'll see a lot of people dwell on how to size. Do you measure the intertrigonal distance? Do you measure the height of the anterior leaflet? Do you measure this and that? At the end of the day, there is no real science behind it, and it's just anecdotal. Also, for the reference of the P1, using P1 as a reference, that's all anecdotal. I mean, there's no clear evidence to suggest that P1 is less affected by valve pathology than the other parts of the mitral valve. So again, it's mostly now we're in Tyrone David used to say, this is where science ends and art begins. And once you go beyond the mitral valve pathology and exposure and everything, now you get into the artistic part, which each and every surgeon there are different schools. And at the end of the day, each one of you will develop their own technique based on experience, based on the learning curve, based on exposure, based on convictions, and we'll develop it as they go along.
So, Dr. Rakan, I have one question. When you analyze the valve, what is your reference point? Where is the normal?
Okay, so before I analyze the valve, Faisal, and this one point I also forgot to mention, I rely heavily on the preoperative echo. Not even on the echo done inside the operating room, but the echo and the TEE done before taking the patient to surgery. I already have a playbook plan and everything based on what I see on the preoperative echo. So if once I decide, and again, if you have a good echocardiographer who can give you excellent images, especially with transesophageal echo, then I go into surgery knowing exactly where I'm going to resect, whether I'm going to resect or respect, where I'm going to suspend, exactly what I will do. Now, for the mitral valve exposure, once I expose the mitral valve, and as those who scrubbed with me know, before I even look at the valve, the first thing I do is put the annuloplasty suspension stitches first. And this allows you to bring the mitral valve closer into the surgical field and into view, rather than trying to probe the mitral valve while it's deeply seated inside the left atrium. So before even looking at the valve or testing the valve, after opening the left atrium or the transeptal approach, I will suspend the mitral annulus and bring it into view. And then I will start testing the valve. You test by doing the injection test to test the where the mitral regurgitation jet happens. You want to take the nerve hooks and start probing quickly. But most of the time nowadays, I mean, I used to spend time analyzing the mitral valve. Nowadays, I don't spend much time because I already go in knowing exactly what to expect based on the echo.
I see, doctor. So you basically made up your plan before even the skin incision.
Absolutely, absolutely. I mean, sometimes you will be surprised, especially you'll be always surprised with endocarditis. What you see on echo really underestimates the destruction that you find when you open the mitral. But in general, for degenerative mitral disease, specifically mitral valve prolapse, echo is an excellent modality. It tells you what you need to do. And nowadays we have the technology of 3D echo, which makes it even much better because you know exactly how the valve will look. Even better than what you see in surgery because you're seeing the functional anatomy. You see real live 3D echo images while the valve is working in a beating heart. So you really understand, I can, looking nowadays by a good 3D echo image, will exactly tell me if I need to resect, if I only need to suspend, if annuloplasty is enough, depending. Echo is an amazing tool. And again, it's one of these things, you can only learn it by spending a lot of time in the echo lab and viewing echo images and correlating what you find intraoperatively with the preoperative echo images.
I understand, doctor. Thank you. Dr. Idris?
Yes.
I still have half of my presentation and now it has been an hour. Would you like us to have a break or it's okay for me to continue? After Dr. Rakan's permission.
I think we should continue and maybe keep the questions for when we finish.
Okay, no problem.
Okay, thank you.
So now I will continue with the techniques for type 2 dysfunction, but mainly the anterior mitral leaflet. So for type 2 dysfunction, as we said, is leaflet prolapse. And for anterior leaflet prolapse, normal mitral valve function implies that the free edge of the leaflet remains at the same level and a 5 to 10 millimeter below the plane of the orifice during systole. So your coaptation line has to be 5 to 10 millimeter below the annulus. Leaflet prolapse or functional Carpentier type 2, functional type 2, is a valve dysfunction in which the free edge of the leaflet overrides the plane of the mitral orifice during systole. It should be differentiated from bellowing leaflets seen in Barlow's valve. As you can see in this picture, Barlow, the main feature of it in echo is excessive leaflet tissue with bellowing leaflet. But as you can see here, the free edge of the leaflet is still below the annular plane. Once it goes above the annular plane, now it becomes dysfunctional with regurg, either because of chordal elongation or chordal rupture. So in which the free edge of the leaflet remain below the plane of the mitral annulus. However, a leaflet prolapse may complicate the course of this disease. So several surgical techniques have been developed to correct anterior leaflet prolapse. The choice of the appropriate technique depends upon the anatomical condition and also the surgeon's preference. As you heard Dr. Rakan, there are two schools. Some people resect and some people respect the leaflet tissue. So those are also important aspects of the repair strategy. So the choice of the appropriate technique depends upon the anatomical condition. Either the extent of the prolapse, which is the length of and the number of leaflet segments involved, which are prolapsed, the degree of prolapse, which is how much of the leaflet is overriding the annulus plane, and the lesion producing the prolapse, either it's chordae or papillary elongation or chordae or papillary rupture. So you can divide, as we said here, it's depend on the extent of the prolapse. Carpentier divides it into limited and extensive prolapse. Limited prolapse, it is when the part of the leaflet, the free edge of the anterior leaflet that is prolapsing is only 1/4 of the height of the leaflet. So whenever the prolapsing segment is only 1/4 of the height of the leaflet, this is a limited prolapse. The types of repair techniques used, there is the leaflet triangular resection and the leaflet's fixation on secondary chordae. So the height of the triangle resected should be slightly longer than the base. I will show you the picture now. And the resected area should not be more than the percentage of the, it should not be more than 40% of the anterior mitral leaflet surface. Sorry, by mistake, the number was not here. So as you see here, I used to have picture, I'm sorry. This is the picture. So your triangle, its height should be more than its base. Your resected triangle, it should not involve more than 10% of the anterior leaflet surface. And once you resect, and your resection has to be, the line has to be curvilinear in order for both edges to attach properly. And then you start your matrix suture, you do it in an interrupted fashion, and you can tie your knots underneath toward the ventricular aspect of the anterior leaflet. And then you put your Aneuplasty. As I said, after each repair strategy, it has to end with an Aneuplasty. You have to stabilize your annulus. The second is leaflet fixation on the secondary chordae. As I told you, whenever it is less than 5 millimeter, the prolapsing segment, you can just attach it to the secondary leaflet. But this is a technique, I think it's an archaic and nobody uses it, because I think the bad thing about this, this technique is you are using a diseased tissue, like in patients with degenerative mitral disease, fibroelastic deficiency, or Barlow syndrome. You are using a diseased tissue as a basis of your repair, which can also rupture or elongate and render your failure, your repair non-functional. For these two I mentioned were for limited prolapse, the triangular resection and fixation on the secondary chordae. For extensive prolapse, which is more than 1/4 of the height of the leaflet, we have 3 techniques according to Carpentier: artificial chordae, and the secondary chordae transposition, and posterior mitral leaflet chordae transposition. I will, and these are used only for patients who have extensive prolapse caused by chordae rupture. So I will go extensively mainly on the artificial chordae. So for extensive prolapse with chordae rupture, you use neocords made from polytetrafluoroethylene or PTFE. The main difficulty for this technique is sizing or choosing the length of your newly made cords, and the adjustment of this length to the tip of the papillary muscle and then the leaflet edge. So another difficulty also is this material, the PTFE threads, are difficult to tie because of the friction. So once you put your first knot, it's very difficult to slide or untie. So it needs experience to get the proper sizing. There are multiple techniques. You can either adjust to the height of the loops on the leaflet level, or you do it on the ventricular level. And there is this technique, which I have seen multiple times, especially in minimally invasive approaches to mitral valve repair, which is the pre-measured loops, which is you create your own loops in vitro, if that is a correct word to use. You use it before you put it inside the patient valve, and then you implant it in the papillary and the leaflet. So this is a picture to show you the methods of creating your own loop. So as you can see here in A, there is a ruptured chordae, and you can see here A1 is prolapsing due to this ruptured chordae. So first you have to put a suture to tether the leaflet and extend it to its normal level. So you have a reference point, and you have to use a non-elongated chordae. Then the length of the leaflet is measured using either graduated hook, or you can just use a marking pen to mark the leaflet height. So you put your PTFE bite, you put a figure of 8 on the papillary muscle tip. It's better to put it on the fibrous edge than to put it in the muscle itself, so you don't jeopardize the blood supply. And then after you tie, you can either mark with a marker pen on the suture or use a graduated hook. Once you have chosen your height, you can just tie, put the needle through the leaflet again and tie your knot under the leaflet. And this is the end result. The other technique, it is almost similar, but it is on the papillary muscle level. And this is what I told you about a pre-measured loop. Usually you use a caliper, which is this instrument, to measure the distance between the papillary muscle and the distance between the papillary muscle and the leaflet. And then you make your own loop around this caliper. There are 2 videos, you can watch them. They're like 10 to 15 minutes. This is for pre-measured loop, and the one which you adjusted at the leaflet level. So for patients with anterior leaflet prolapse and extensive prolapse due to chordal elongation, you can either, if the chordae elongation is less than or equal to 1 centimeter, you can use either papillary muscle sliding plasti or papillary muscle shortening. If it is more than 10 millimeter, you shorten your chordae. But these do not respect the leaflet tissue or the papillary muscle tissue. These all involve resection, these techniques. So this is the technique I told you first. This is the papillary muscle sliding plasti. As you can see, first as you see here, the chordae are ruptured. You use these whenever the chordae are elongated 1 centimeter or less. You measure the amount of elongation in each chordae you want to repair. And then you go to the papillary muscle, which is attached to this chordae, and incise with an 11 plate in the middle of this papillary muscle, the same length of elongated chordae, and then put your suture in this fashion in order to reduce the height of this half of the papillary muscle, as you can see here. So the distance of the chordae attached to the papillary muscle will be almost equal to the one which you have measured in the first. And then this is your end result. The other technique, which is papillary muscle, sorry, I forgot the name, papillary muscle shortening, which is you have to, it's the same thing. You attach one papillary muscle to a neighboring papillary muscle, which has non-elongated chordae, with the same height as the elongation, as you can see here. But one thing you have to bear in mind, you should never take a papillary muscle past the midline, because this will apply more tension over the chordae. So it should be on the same side of the midline of the anterior leaflet. This is the technique you use for if the elongation is more than 1 centimeter, which is what we call chordae shortening. So as we said before, it's indicated if it's more than 1 centimeter, you measure the excess length of the chordae and the elongated part of the chordae, and then you make an incision through the papillary muscle, not a full thickness incision, to preserve the blood supply of the papillary muscle, but it has to be half of the elongated part. Then a suture is passed through the papillary muscle around the elongated chordae and out of the other side. Once you apply tension, you will fold this chordae inside the papillary muscle, shortening that chordae, and then you can close the papillary muscle with interrupted suture. As you can see here, your chordae in general, and in the next techniques I will mention, should never touch any suture, because this will increase the risk of abrasion, and chordae rupture. This is also another technique used, which is papillary muscle shortening. You take a wedge of the papillary muscle and then you tie it in order to solve any chordal elongation. Another technique, which is this one, where you put this figure of suture and then tie it tightly in order to do like a purse string effect of the papillary muscle, shortening it. This is just a table summarizing all the techniques I have said and when to use them. So patient with extensive prolapse caused by papillary muscle rupture, you can use either papillary muscle reimplantation or head reimplantation. Patients who have extensive prolapse due to papillary muscle elongation, you can use papillary muscle shortening or papillary muscle plication. This is the technique of papillary muscle implantation, which I have not seen actually, and I could not find any videos regarding this technique. But as you can see, the ruptured chordae is taken, and an incision is made into the LV, and as the technique is named, it's implanted into that groove, and the groove is closed, taking care not to have any suture touching the chordae to reduce the risk of abrasion. This is papillary muscle shortening. It's the same technique I have showed you before. 2 sutures on each side, and then you tie it, causing a purse string effect. Or you can just incise this part of the fibrotic part of the papillary muscle and suturing it to the healthy part of the papillary muscle. This is just a summary of the techniques I have mentioned. And now we will go to type 2 dysfunction regarding the posterior papillary posterior mitral leaflet type 2 dysfunction. But before I go, anything you need to add, Dr. Rakan, for what I have mentioned?
No, Faisal, actually, you did an amazing job. But again, I have to reiterate that you're relying heavily on Alan Carpentier's textbook, which has amazing illustrations. Most of the techniques you described are hardly done nowadays.
Okay.
You know, artificial chords have become the mainstream practice. Now, Alan Carpentier used to spend 6, 8, 9 hours on cross clamp, just trying to repair each and every individual chord with all of these different fancy techniques. You know, nowadays it has been proven that as long as you leave diseased valve part, no matter how much you shorten, you elongate, whatever you do, that valve, the native structure of that valve or that chord or that segment is abnormal. So recurrence is very high. So the best thing is just to replace with prosthetic material, an artificial cord. For the anterior leaflet, basically to me, it's artificial cord. My anterior leaflet prolapse, that is. It is artificial cord. For the posterior leaflet, you can use a mixture of, you know, quadrangular resection, triangular resection, sliding plasti, artificial cords, whatever. And at the end of the day, the idea of mitral repair, remember, the mitral valve is the anterior mitral leaflet. The posterior leaflet is just there to provide a supportive frame. It's like a door frame to house the movement of the anterior leaflet. And whatever you do, if you have a posterior leaflet prolapse, technically it's very easy. Whatever you do will work, because you don't need to do much. All you need to do is eliminate the redundant segment, either by resection or plication or just fixating with the Aneuplasty band. Now, the tricky part becomes the anterior leaflet, and I think artificial cords have shown that it's reproducible and quite easy and doesn't take much time. The question is always how high, how long should you construct your artificial cord? Each surgeon have their own technique and concoction. Some are really, you know, are number crunchers, so they like the measurements. And the device you showed is called the Friedrich Mohr measurement device for the leaflet height, or for the chordal height. I tend to use a much simpler technique called Khoury technique. It's basically, I do a loop around the papillary muscle head and bring it out the 2 or 3 millimeters from the edge of the anterior leaflet where the prolapse segment is. And I lift the leaflet a bit high to the level of the annulus, and that would be my height, and then lock it with another, with a locking loop at the edge of the leaflet. And to me, that has worked quite well. I mean, each one of us will have their own way of doing these techniques, but I always say, if you want to have successful reproducible surgery, you have to make it easy. You have to deconstruct it. At the time of Alain Carpentier, when he described his technique, it was more artistic. You know, it wasn't structured. It was basically artistic. Now, as you know, our experience has greatly enhanced, and the reproducible experience has become a wide practice. You have to really deconstruct it to a simple reproducible steps. And I think for the posterior leaflet, again, as I said, artificial cords plus or minus, it's plus or minus a combination of artificial cords, triangular, quadrangular, or sliding plasti. For the anterior leaflet, it is basically artificial cords. Now for the commissures, I used to do the magic stitch, which is again an Alain Carpentier thing, is basically you close the commissure, khalas. What you don't see does not exist. So basically, if the commissure is causing a leak, you just close that commissure with a running 4/0 stitch, and that will be it. Just making sure you don't make the opening stenotic. But I've adopted now other techniques, such as putting artificial cords on the commissural leaflet, or doing what they call, what you described here, is a papillary head relocation, which is basically you stretch the papillary head away from the commissure so that it's more tethered.
So, Dr. Akan, I have one question. If you are about to implant more than one chordae.
Yes.
Alain Carpentier mentions that the distance between each chordae should be no more than 4 millimeters. Is that a rule you also use, or?
No. So basically, for the artificial cords, one thing I look at the native cords, where they originate. So I try to respect the native anatomy. So basically, I wouldn't implant an artificial cord in a papillary muscle head that doesn't correspond with the surrounding cords. And for each segment of the valve, all you need is just one loop. So basically, when you use a 6/0 Gore-Tex or a 5/0 Gore-Tex to reconstruct the artificial cords, I basically take one loop on each segment. So for example, the anterior leaflet is 3 scallops, or theoretically are 3 scallops. So if all the anterior leaflet is prolapsed, which is rare, I do 3 artificial cords loops. So each loop is basically 2 ends, and that will be enough for me for that segment. Same thing for the posterior leaflet. So you really don't need to do many artificial cords, and the distance really doesn't matter, as long as that part of the valve, that segment or that scallop, is put at the right height. Also, another thing you really need to be cognizant of, especially if you do resection, whether it's triangular or quadrangular resection or sliding plasti, is when you always resect far less than what you need to resect. Because if you resect the whole pathology, you're very likely to lose valve tissue that is important to keep the valve competent. And you really need to leave some material, some distance, 2 or 3 millimeters on each side for you to sew. For your stitches, your bites are going to take some space. So you really need to leave some margins for these stitches, your 4/0 or 5/0 Prolene, to take your bites. So always resect far less than what you think you need. And when you resect, sometimes you open subcommissures, so small scallops at the edge of the mitral leaflet, because again, now you've shrunken the leaflet and these edges will open up. And when you test, you will have some small commissural leak or subcommissural leak. And then you have to close them with 6. They can be cumbersome sometimes. And you have to close them with a running 6/0 or a mattress of 6/0 Prolene.
I see. Thank you, Doctor. So for the next part, we will talk about also type 2 dysfunction, but only related to the posterior mitral leaflet. For the posterior leaflet prolapse, type 2 posterior leaflet dysfunction is the most frequent dysfunction in mitral valve regurgitation by degenerative valvular disease. It's caused by degenerative valvular disease. The prolapse usually affects, and most commonly, P2, but can be extended to P3 and more rarely P1. Over time, the leaflet tissue becomes distended with proliferation of pathological tissue. The P2 segment may be 2 to 3 times the normal size. So we will be dividing it the same as the anterior leaflet. Either it's limited prolapse or extensive prolapse. A limited prolapse of the posterior leaflet, it's when less than 1/3 of the free margin is involved in the prolapse. So when I say 1/3 of the segment circumference, so P has to be 1/3. If it's more than 1/3 the distance of A, that's an extensive prolapse. So this is one technique that was mentioned for the repair of such pathology, which is Magoon's plication technique. And this is a technique where it respects the leaflet tissue. But for Carpentier, he mentioned all three techniques, which none of them respect the tissue. Actually, they all resect it. So for the triangular resection, this is one technique you can use. It is indicated, as I said, whenever the length of B here, of the free margin of the prolapse segment is less than 1/3 of A. Another technique you can use is transposition or replacement of the chordae when there is no excess leaflet tissue. When you have prolapse, but there is no excess leaflet tissue, you use a transposition and replacement of the chordae. This is where the surgeon transfers a secondary or basal chordae to the free margin of the leaflet, and then chordae shortening when the prolapse is due to chordae elongation in the absence of significant excessive tissue. So this is the technique of triangular resection. As we said, first you put your, here we check that the margin is less than 1/3. You put your stay suture just to unfurl the posterior mitral leaflet and put some tension on it so it's all apparent to you. And then you measure the height. The height of your triangle should be slightly longer than the base, as in the anterior leaflet triangular resection. After you have resected your triangle, the sides should be cut, as I said, in the anterior leaflet should be curvilinear. You can see the line, it's not a straight line, it's curved. The leaflet are then sutures together in interrupted sutures. The knots, it depends on the surgeon. You can place them on the atrial side or the ventricular side. Then after you have placed your suture, you check with the nerve hook for any defects. If there is any defect, you just close it. As Dr. Rakan mentioned that when you do triangular resection and you sometimes take excessive tissue, you can expose some of these indentation between the scallops and cause new regurgitation. This can be fixed with the, I think I can call this a magic stitch. You can just put a stitch and close this regurgitant area. For extensive prolapse in posterior leaflet, which is more than 1/3 of the base of the posterior leaflet segment, there are multiple techniques. There is the quadrangular resection with annular plication. It can be symmetrical or asymmetrical, as you can see here. This is the quadrangular resection. As you can see here, you cannot do for this type of prolapse when there is an excessive tissue, more than 1/3 triangular resection, because a curtain effect will happen, because there is not enough tissue, normal tissue, to support your segment. So when you take a triangle, it will cause some tension and cause more harm than good. Another option you can do is leaflet sliding technique. And this technique is primarily indicated in extensive leaflet prolapse if the gap is equal to or greater than 20 millimeter. I mean, the gap whenever you resect a quadrangular part. And I will show you in the next slide. And then you can use composite techniques whenever there are multiple issues. So leaflet resection should be limited, as I said, to 40% of the total surface area. If the prolapse is more extensive, a partial quadrangular resection is performed, removing the most diseased part of the prolapsed area, and then the remaining prolapsed area is corrected by chordae transposition or replacement, whenever there is not enough tissue for resection. If chordae are elongated and not ruptured, papillary muscle sliding plasti can be done. You can see here, this is the quadrangular resection. Leaflet are put under tension with this stay suture. The diseased part of the P2 segment is resected. And then the secondary chordae as you can see here in P, are resected because you will need to suture both of these sides. You have to measure the height and the distance between both sides. If they are both, all these dimensions are less than 20 millimeter or 2 centimeters, you do your annular plication, and then you suture both edges together. After that, you can see you will test your repair with a nerve hook. If there is any defect, you just put a suture on it, and then you complete your repair with an annuloplasty ring. This is in case if you do quadrangular resection and either one or both sides are more than 20 millimeter. This is when you will just reduce the heights of both leaflets and do a form of sliding plasti, and then complete your quadrangular resection with annular plication, either on one side or two sides, and suture both sides together. This is another technique, which is sliding plasti. This is when the gap between both edges is more than, you can use it when it's more than 2 centimeters. What you do is you have to resect the leaflet bases half of the distance between each edges. So if it's 2 centimeters or 10 millimeter, you will cut here 10 millimeter and here 10 millimeter. You will resect your secondary chordae, place multiple sliding sutures. As you can see, it will go through the annulus, then come back partially through the annulus into the ventricle and back into the atrium. And you will place multiple. These sutures, once you tie them, they will cause a purse string effect and reduce the distance or the circumference of your annulus. After you have done that, you can just either you can tie these sliding sutures or use them as part of your ring sutures, as you can see here. Or, and after that, you will do a continuous horizontal matrix suture to suture your posterior leaflet toward the posterior annulus. This is a summary of the techniques I have just mentioned for the posterior mitral leaflet whenever there is a type 2 dysfunction. So anything to add, Dr. Rakan, or I can just go
and we'll move on, yeah.
First one? So just one last thing, just always be careful on suturing beyond the posterior annulus, because you increase the risk of capturing the left circumflex, especially in a left dominant system. So if you have a patient with a left dominant system, I really discourage doing any stitching in the annulus. Annular plication used to be done, but nowadays triangular resection has made it less in demand, as well as the artificial cords. And if the whole posterior leaflet is prolapsed, then you can do the sliding plasti with or without resection of the middle segment.
But the sliding plasti involves sutures in the annulus.
Yes, in the annulus, not in the beyond the annulus. Okay. So it's basically the problem. My problem with the quadrangular annular plication is you're taking. So there is a technique, by the way. You don't sew in the annulus for that gap in the posterior annulus that you need to plicate. Go back one more. Come on. No, one more. One more. Come on. Go back. There is a part where you show the needle being taken in the annulus.
It's not. I think it's this one you mean, Doctor. It's this one.
Yes. So when you take your when you're doing your this is you need a sliding plasti here. But when you're doing a quadrangular section, go to the one before this. Yes. So when you're taking your needle in the annulus, you really need to see the tip of your needle underneath the annulus. So you take a bite. So you don't take the see that the bottom part here where the last one at the bottom. Okay, see that plication stitch beyond the leaflet? beyond the annulus, the white one.
This one.
Yeah. So this one you need to really be careful, and I would discourage doing this in a left dominant system. So what you need to do is take multiple bites. You don't do it with a single bite. You take a bite in the annulus, bring it from underneath the valve in the LV, and then take another bite from the left ventricular side towards the left atrium. And then you take another bite. But again, I would only do this if it's a right dominant system. In a left dominant system, you will be very close to the circumflex. That's my only caution.
I see. Thank you, Doctor. So for now, we will go to type 3 dysfunctions and the techniques that are used to repair such dysfunctions. So type 3A, which is, as we said, restricted leaflet motion in the diastolic phase. It most commonly occurs with rheumatic heart disease. The limitation of motion of the leaflet is due usually either commissural fusion, leaflet thickening, chordae fibrosis, and calcifications. These lesions produce either pure mitral valve stenosis or mitral regurgitation or combined. So for mitral stenosis, mitral valve stenosis was the first mitral valve dysfunction to be treated surgically by closed surgical commissurotomy. And I provided a picture here on the right side depicting this procedure, which has been replaced by balloon valvuloplasty. So in valve stenosis, the fibrotic lesions are predominant at the commissures and in the zones of the leaflet coaptation. The fusion of the commissures generate turbulence, which is the main cause of platelet and fibrin deposits, and ultimately calcification. The underlying subvalvular apparatus is fibrotic and sometimes retracted. So in mitral stenosis, there are multiple lesions, either commissural fusion, which can be treated with commissurotomy, or subvalvular lesion, such as chordae, and you can treat these with chordae resection and fenestration, and annular deformation. This can be repaired with ring Aneuplasty. So this is just to depict dilated annulus that can also be caused by, as you can see here, the commissures are fused, and also the annulus is dilated. So you have to repair this with a commissurotomy and an annuloplasty. Because if you do commissurotomy only, you can see how the annulus is more dilated, because what was holding the annulus is the commissural fusion. So an annuloplasty is a very important thing. But if the annulus is normal and you do your annuloplasty, it will remain the same. This is a cartoon just to depict the commissurotomy procedure. So commissurotomy, from its name, is to open the commissures. So first you need to identify the commissures, which can be sometimes hard in patients with rheumatic heart disease, because you can never see the line of the commissures. One technique you can do is with the nerve hook. You can hold one of the marginal chordae and retract on the anterior chordae, and you will see a line between the posterior and the anterior. That is your commissure. So with an 11 blade, you start your incision into the commissure, but you don't start from the annulus. You need to leave a 5 millimeter at least segment to prevent any leak. So once you have made your incision, you make it until you reach the margin and you stop. And you don't complete your incision through the whole leaflet. You need first to go down to the chordae and papillary muscle level, identify the commissural chordae. Once you have identified, you have to separate into half with the papillary muscle. Once you have done that, you can now separate the leaflet. And the rule that Carpentier used, that your commissurotomy is appropriate whenever you can put a thumb sucker under the anterior leaflet. So once you have done your commissurotomy, then you assess the subvalvular apparatus. If there is any chordal fusion, you can do fenestration, as you can see here, between the chordae, or you can do chordal resection, as you can see here. But whenever you do your chordal resection, which is cutting the restricted chordae or fibrotic chordae, you cut first from the papillary muscle, then you cut from the leaflet. So because if you start from the leaflet, you might cause a defect in the leaflet by starting your resection from the leaflet itself. You can see here, this is a normal annulus. As I said, after commissurotomy, the annulus is normal. because it's normal, there is no deformation of the annulus. Here, if it is circular, not an ovoid, normal shape, you need to put an annuloplasty ring. So in patients with diastolic restriction and with mitral regurg, two key features have a direct impact on the decision of what surgical technique to use: the surface area and pliability of the anterior leaflet, and the severity of the subvalvular lesion. The most common lesions are in such dysfunctions are annular dilatation, commissural fusion, leaflet thickening, and chordae thickening and fusion, and minor prolapse of A2. And this is a table that I found in the book of Carpentier, just to tell you the feasibility of each repair. If you assess and you find that there is a minimal subvalvular lesion and pliable leaflet, the repair is feasible. But if there is a severe subvalvular lesion and calcification, it is possible, probably not feasible. If it's poorly pliable, but there is minimal subvalvular lesion, probably feasible with leaflet extension. But if it's both non-pliable and with extensive lesions, it's most probably not a feasible repair to conduct on such valve. So in patients with mitral regurgitation due to leaflet restricted motion, you can use leaflet mobilization, which I will show you in the next slide. If there is an A2 prolapse, you can use chordae repositioning. The choice of repair technique depends on the prolapse mechanism. If it's due to posterior displacement of the paramedial chordae, or either it's due to predominant lateral displacement of the paramedial chordae. And then another lesion that can cause mitral regurgitation is leaflet thickening, retraction, and calcification, and this can be treated with leaflet extension. This is what I told you about, which is if there is a minimal A2 prolapse, you can just attach it to the secondary chordae, which we have seen in the anterior leaflet prolapse when there is a type 2 dysfunction. This is a chordae translocation whenever there is a restriction causing regurgitation. But also this kind of repair method has the disadvantages that you are using a diseased tissue. If you use it for your repair, the disease process will continue and your repair will fail. Another thing you can use for restricted leaflet motion is leaflet extension, as you can see here. But if you're doing it for the posterior leaflet, your incision should be a little bit away from the annulus, at least 5 millimeters, and you should bear in mind that you need some distance for your sutures in order to put your sutures, so don't be so close to the annulus. It should be, it doesn't need to be symmetrical, it depends on the deformation of the posterior mitral leaflet. The posterior leaflet should be between 15 and 20 millimeters, not more than that, because you will increase your risk of SAM. Once you have done your posterior leaflet extension, you will put your ring, but you will size it according to the anterior leaflet, not the posterior leaflet. The same is for the anterior leaflet. You can extend it to however you like, either it's in the septolateral dimension or the transverse dimension. If there is any calcification, you can remove it and patch the anterior leaflet to extend it. So in patient with type 3A and ring annuloplasty, a large orifice area and optimal leaflet pliability are essential to achieve long-term function of the mitral valve. A ring should be implanted even if the valve appears competent after leaflet mobilization or extension. Whenever the posterior leaflet has been augmented, the ring is selected should be one size larger. Whenever the anterior leaflet has been augmented, the ring selected should be the same size as the size that covers the anterior leaflet and the patch. So according to Carpentier, and as Dr. Rakan says, this differs between each surgeon, but this is what I read. If you augment the posterior leaflet, you measure the anterior leaflet and use the one size larger. As you can see here, the size is 32, he put a ring of 34. But if you augment the anterior leaflet, you measure the size of the anterior leaflet and with the patch, and you use the same size. You don't oversize. The last part when it comes to the types of or the techniques for repair when it comes to the Carpentier functional classification is the type 3B dysfunction, which is the restricted leaflet motion in systole. It is the most important functional characteristic of type 3B is pure systolic restricted leaflet motion with preserved leaflet pliability. The most common causes are ischemic myocardial disease, idiopathic dilated cardiomyopathy, or end-stage heart disease from other causes. The shared feature between all these etiologies of the leaflet during systole is either segmental dilatation, which is asymmetrical tethering, if there is a segmental dilatation of the heart, as you can see here. The infarction or the ischemia only involve the posterior wall of the heart, so it's only involved the posterior leaflet and restricted its motion and only one segment. And it can also be global dilatation causing symmetrical dilatation, as you can see here. Both the anterior and posterior are restricted due to the heart dilatation. So in case of segmental dilatation, it's usually seen in ischemic heart disease. It results in asymmetrical apical and lateral displacement of one papillary muscle and tethering of the corresponding leaflet segment. As we said before, due to the anatomy, the posteromedial papillary muscle is most frequently involved due to its blood supply. It usually produces systolic restricted leaflet motion of P2 or P3 and the posterolateral commissural segment, sometimes A3. In addition to asymmetrical leaflet tethering, the annulus is also asymmetrically dilated, as you can see in this picture. One important point or interesting point I want to add is that in the past, people used to think that the reason for such pathology is the papillary muscle. But according to Carpentier and his animal experiments, when they used to inject formaldehyde into the animal's heart. First, they injected them into the papillary muscle. But after doing that and dysfunction, causing the papillary muscle to be dysfunctional, the tethering and the regurgitation did not happen all the time. Only when they injected the formaldehyde into the LV wall and the papillary muscle, this is when consistently the leaflets were tethered. Another thing I want to mention also in this picture, if you can see the leaflet, the anterior leaflet shape. I don't know if any of you have ever heard of a deformity called the Seagull Deformity. As you can see here, and it's mainly seen in echo, the anterior leaflet is tethered by the secondary chordae, causing this Seagull Deformity, which can mainly be seen in echo. So the annular remodeling and ring implantation in patients with segmental dilatation, you would usually use a complete ring and you will undersize that ring. Okay, you will never use an incomplete ring. You should use a complete, either rigid or semi-rigid, and you should undersize it. For the global dilatation, it causes symmetrical dilatation of the annulus and tethering also of the leaflet. Displacement of the papillary muscle is also symmetrical. Global annular dilatation can be treated at the annular level by a complete remodeling of the annulus. The size of the selected ring is downsized 1 or 2 sizes. One last thing I want to mention regarding this kind of pathology, which is either dilated cardiomyopathy or ischemic cardiomyopathy, the disease is not in the valve. Actually, it is in the myocardium. So even if you notice in the guidelines, there is no class 1 indication in patients with functional mitral regurg, because actually whenever you intervene, you're just hindering the process of the disease. You're not treating the disease. So the next segment is the last segment, the segment before last, which is systolic anterior motion. But before I go to it, do you, Dr. Rakan, have anything to add to the type 3B dysfunction or anything I just said?
Functional MR is a whole topic on and of itself, and there's a lot of debate. Should you repair? Should you replace? What is the outcome, and so forth? Is it ischemic cardiomyopathy versus cardiomyopathy on and of itself? all I can say is if the regurgitation jet is central and the LV is not in diastolic dimension is less than 6.5, then a simple downsized annuloplasty ring will work. If the jet is more than moderate and eccentric, then an annuloplasty alone will not work. And then you might need to do adjunct interventions, which is second order cord sacrifice, artificial cord, leaflet extension, papillary muscle sling, edge-to-edge repair. I think when it gets more complicated like this in a cardiomyopathy patient with an eccentric jet, just replace the valve and get, and save the patient's life. Going back to the rheumatic repair, I would not advise any one of you to repair a rheumatic mitral stenosis, period. Just replace the valve, even in a young female in childbearing age. Give her a tissue valve, she can come back for a valve or redo. For a female of childbearing age, I would only attempt to do a rheumatic mitral repair if the anterior leaflet is mobile and the main lesion is regurgitation rather than stenosis. Then what I do in that situation is do a posterior leaflet augmentation, and I've done that in the past. Durability of these, not very well known, but we are talking about an average of 5 to 8 years, which is again enough time for the patient to have their children and resume life until she gets back for a redo.
Okay, so to continue with the systolic anterior motion, systolic anterior motion is an important topic to cover whenever we are talking about mitral valve repair, because it's one of the possible complications that can happen after you repair if you did not do it properly. So systolic, which is abbreviated as SAM, it is a systolic displacement of the distal portion of the anterior leaflet of the mitral valve toward the LVOT. SAM usually results from a discrepancy between the amount of valvular tissue and the mitral valve orifice area. It has two possible consequences: LVOT obstruction and mitral valve regurg. It is most commonly seen in patients with hypertrophic obstructive cardiomyopathy or HOCM, or patients with Barlow's disease after mitral valve repair. So the pathophysiology of SAM, it is usually, as I said, a mismatch between the amount of leaflet tissue and the size of the reconstructed mitral annulus. And this is what usually triggers SAM. It has multiple risk factors, but two major ones that need to be known after mitral valve repair. Either you left an excess leaflet tissue, as you can see in this picture near the letter A, or you have undersized your annulus. There are other additional potential contributing factors like a narrow aortomitral curtain, if your LVOT is near the anterior mitral leaflet. A small hyperkinetic ventricle can also cause that. When I say hyperkinetic, this translated clinically into tachycardia, which is something you have to correct, and we will talk about. An abnormal configuration of the anterior leaflet, and the severe left atrial dilatation, and an abnormal configuration of the anterior leaflet with an increased height of this leaflet, if you have an excessive tissue, in other words. So these factors, if they are present in the patient and you notice them in the echo, you can predict who is at high risk of SAM after your repair. SAM usually occurs when either two major, according to Carpentier, or one major and two minor risk factors are present. So to continue in the pathophysiology of SAM, the blood flow and the problem that happens with SAM is that it affects your blood flow. And part of your pathophysiology, the pathophysiology of SAM is the way the blood flows into the LV and affect the movement of the anterior mitral leaflet, leading to obstruction and regurg. And there are multiple phases. So in early diastole, as you can see here, the blood flow normally and usually it should be directed toward the apex. But because of either narrow anterior mitral aortomitral angle, or because the anterior leaflet is abnormally shaped, as you remember in the beginning of my presentation, I said the anterior leaflet helps create the inflow and the outflow tract. So if it's abnormal, it will affect also the inflow tract. So that the flow in patients with SAM is actually directed toward the septum. And this also affects the anterior mitral leaflet movement and push it toward the LVOT. During the phase of isovolumetric ventricular contraction, the forward flow from the LV toward the LVOT is normally, as I told, as you expect, is toward the LVOT. But in patients with SAM, the anterior mitral leaflet is in front and obstructing this LVOT. So the ventricular, as the ventricular volume diminishes during the isovolumetric contraction, the anterior leaflet closes, but the excess tissue of the posterior leaflet occupies approximately 2/3 of the mitral valve orifice and pushes the belly of the anterior leaflet toward the LVOT, as you can see here. Because of the flow going into the septum and coming back under the posterior leaflet, the orifice is mostly occupied by the posterior leaflet, preventing the anterior mitral leaflet from using its all height to close the orifice itself. So it's lingering here in front of the LVOT. So during the systolic flow displaces the distal portion of the anterior leaflet toward the aorta, resulting in varying degree of turbulence and ventriculo-aortic obstruction, as you can see in this picture. And the last step, or the last phase of this SAM, the systolic flow further displaces the anterior leaflet, as you can see here, toward the LVOT, separating the coaptation surface, leading to MR. So how does SAM present clinically? SAM can present to you either intraoperatively or postoperatively. So intraoperatively, after your repair, the typical presentation is in a patient with Barlow's disease after mitral valve reconstruction. And in the TEE, you will see the following characteristics. You will find an excessive tissue of the posterior leaflet, excess tissue of posterior leaflet. You'll find an anterior displacement of the distal portion of the anterior mitral leaflet associated with LVOT obstruction. And there is, at the end of the systolic phase, mitral regurgitation with the jet-oriented posteriorly. Whenever you are faced with such scenario, there are three things that you can correct before thinking about intervening surgically. First, if the patient is dry, if the LV is suboptimally filled, you have to give the patient some volume. That can also correct, because if the LV is empty, that could narrow your aortomitral angle. If there is an AV synchrony, like a heart block or any kind of arrhythmia like atrial fibrillation, pace the patient. If the patient is hypercontractile, meaning he is having tachycardia, or there is an increased afterload, you can do that by, increased afterload, you can do that by giving beta blockers or reducing the inotropic support and the chronotropic support. Once you have dealt and adjusted all these factors, you should monitor of both the LV pressure and the aortic pressure in the repeated TEE. And most of the time, 90%, the SAM will resolve. If the SAM persists, the patient should be re-examined to diagnose the reason or to find any correctable reason for the SAM. If you cannot find a reason for SAM, you should replace. Postoperatively, patient can present also with SAM. It can be diagnosed in a patient with residual or recurrent MR. Usually that's how they present postoperatively. Usually there is a variable ventriculo-aortic gradient that increases after inotropic administration, either an echo or cath, if you do the patient cath or echo. In contrast, gradients are usually reduced following volume loading. These are the techniques or the maneuver you can do to reduce the SAM, or increasing the afterload, or administering beta blocker. Most postoperative dynamic SAM disappears within days to weeks after the operation as a result of a process called left ventricular outflow tract remodeling. In the absence of significant improvement after appropriate medical therapy, a reoperation should be considered. So let's say you have tried all the medical or maneuvers that we have mentioned, and you haven't been able to resolve SAM. How can you correct it surgically? Whenever an irreversible SAM has been diagnosed after a valve repair, there are different techniques that can be used depending on the mechanism. Either you have excess tissue of posterior mitral leaflet, or significant discrepancy between the anterior mitral leaflet and the surface area or the orifice area of the ring. So if you have an excess leaflet of the posterior mitral leaflet, you can just reduce its height by just incising and taking a patch of it and suturing it back. This will move your coaptation line from the anterior side toward the posterior annulus. And this will give a space for your anterior leaflet to coapt away from the LVOT. If the problem is because of the anterior leaflet, it's mainly due to small ring. So if you replace the ring with a bigger size, this can fix the problem. But sometimes you have to reduce the height of your anterior leaflet by taking a part of it. The prevention of SAM, you have to, one of the parts of dealing with the problem is to prevent it before it happens. So whenever one or several risk factors of SAMs are identified preoperatively, the surgeon should pay particular attention to two elements during the surgical procedure: the height of the posterior leaflet, not to leave excess height, and the sizing of the anterior leaflet. So you don't put a small ring, or you don't leave an excess tissue of the anterior leaflets. Dr. Rakan, anything you want to add to the SAM part before I move to the last part of my presentation?
No, Faisal, I think you've summarized it very well.
Great. So I'll mention some of the evidence I have passed or skimmed through while I was reading about this topic, just to tell you why repair is better than replacement, especially in degenerative mitral disease. I found this study, which was referenced in the guidelines for mitral valve regurgitation. And it is a cohort retrospective review of a database, international mitral regurgitation database, that involved more than 1,700 patients. And the results of this study, they found that the operative mortality in patients who underwent repair, and they defined it as death within 30 days of the surgery or during the same hospitalization, was lower in patients with mitral valve repair. In mitral valve repair, it was 1.3 compared to 4.7% in mitral valve replacement. In this Kaplan-Meier graph, the 20-year survival of patients who underwent repair is clearly better than mitral valve replacement. 46% of the patients who underwent repair survived beyond 20 years compared to 23%, more than 100%, almost 100% of the people more of the mitral valve replacement. The same thing, they found that there is superiority of repair in patient subsets, regardless of age or sex or any stratification criteria. And they were all significantly, statistically significant. Mitral valve repair was also associated with reduced incidence of reoperation and valve-related complication. As you can see here, this is a freedom of reoperation graph. And you can see in 15 years, there is a small but significant difference between repair and replacement when it comes to freedom of reoperation.
Go back to the first slide, for the survival slide. I just want to point out, yes, this graph. I just want to point out, this is a general point, not related to the specific study. Every time you look at Kaplan-Meier survival or freedom from adverse events, survival curves, Kaplan-Meier curves, look at the number at risk, the bottom line, the bottom two lines. See here, the mitral repair and versus mitral valve replacement. And you can see you started with the whole cohort at 0.0. At 20 years, from almost 1,700 patients, you only have 33 patients. And from the mitral replacement, you only have, from 213, you only have 10 patients. Once the curve passes, the number at risk is less than a third of the original number, then whatever is beyond that point is irrelevant. So, this is visually impressive. You'll see, oh, wow, some repair will live longer compared to, and replacement is bad. This is just a statistical error. What you're looking at, the gap in the curve is just related because a lot of patients are being censored because they've exceeded or they reached the limit of their follow-up and they get censored. So this is, a common statistical mistake that people look. The p-value is significant. That is taken, but still, it's not as bad as the curve would portray it. So basically, if I was gonna look at this curve, I would probably look at the 10-year mark, not the 20-year mark. The 10-year mark is accurate because you still have almost a third of the original number of patients at risk.
Oh, I see, Doctor. So another article I have passed by, which is a meta-analysis that was done in the year of 2008. It was conducted to compare all the results of mitral valve repair with those of mitral valve replacement to determine the optimal treatment option for patients with degenerative MR, particularly according to the patient's age. They conducted a literature research that concluded multiple databases, and this meta-analysis involved 12 retrospective studies that had 2,950 patients underwent repair and 1,252 patients underwent mitral valve replacement. And they found that the pooled analysis showed that the risk of all-cause mortality was significantly higher in the mitral valve repair than in the mitral valve replacement than in the mitral valve repair group, both in all studies. In all the studies, they found this result. This benefit was similar across all ages when the meta-regression analysis and the subgroup analysis were performed. Also, the early mortality and risk of reoperation were also higher in patients with mitral valve replacement group than in the mitral valve repair group. The risk ratio was 4.5, so 4 times the risk of reoperation and early mortality in patients with mitral valve replacement when compared to mitral valve repair. I have here some graphs to show from that meta-analysis to show that the lines for all the study goes in favor of the mitral valve repair. Some of them just cross the midline, which is actually almost 3, but most of them, and you can see here the subtotal is in favor of the mitral valve repair. This is for early mortality after the early mortality outcome. Sorry. Yeah, this is another graph showing the difference in all-cause mortality in all the studies, and it's also showing the same result, which in favor of the mitral valve repair. The last thing is a study regarding the mitral valve repair versus replacement in patients with severe ischemic mitral regurgitation. This one was published in the New England Journal of Medicine in 2013. And they randomly assigned 251 patients with severe ischemic MR to either undergo repair or chordal sparing replacement. So at 12 months, the left ventricular end-systolic volume index among the surviving patient was similar, almost similar. There was not a lot of difference. The rate of death was 14.3 in the repair and 17 in the replacement group, and it was not barely statistically significant. The p-value was 0.45. The rate of moderate to severe recurrence of mitral regurgitation at 12 months was higher in the repair group than in the replacement group. This one was significant. The recurrence of regurgitation was 32% in the patients with repair and 2.3% in the replacement. There were no significant between group difference in the rate of composite major adverse cardiac or cerebrovascular event and functional status or quality of life in 12 months. So the final outcome of composite the final composite outcome of adverse cardiac events or cerebrovascular event were equal between both group, as you can see in this Kaplan-Meier graph. So for the death, in the beginning, there was a big difference between the mitral valve replacement and the mitral valve repair. As you can see, more people died at the beginning of the first 3 months. But after that, the lines almost flat and are parallel. The same you can see also for the composite cardiac endpoint. And this shows you that the answer is still not clear whether to replace or repair in patients with, especially with a patient with severe ischemic MR. By that study, I think I reached the end of my presentation. Thank you for listening and for your attention. Anything to add, Dr. Rakan, for what I have mentioned or to correct?
You did an amazing job, Faisal. You've summarized a lot of very crucial points. Each of the topics you've mentioned is a whole career by itself. My only advice is for our colleagues is basically there is no one right answer to any of this. There are trends, and these trends keep changing as technology and surgical techniques evolve. Get comfortable with all of them. Develop your own niche in each and every one of them. Develop an approach, what you would do in degenerative mitral. Is it stenosis, regurgitation? Individualize your approach for each and every patient, and there is no one fix for all pathology. You cannot use a hammer for everything. You have to individualize your management and always seek advice and help from your other colleagues, especially in these sometimes complex type of cases.
Thank you very much, Dr. Rakan.
Thank you, Dr. Faisal, for the thorough presentation. Thank you, Dr. Rakan, also for your insightful input. If anyone has any questions or comments, please, you're welcome to share.
Dr. Rakan, question, if you don't mind. Dr. Rakan, on what basis will you choose a band or a ring for the mitral aneuplasty? If I'm not mistaken, I heard you saying for the degenerative you will use a band. I'm just not sure, like on what basis a band, or is it a surgeon preference?
It is purely a surgeon's preference, but as in anything in your preference, you have to justify it. So you have to come with the logic why you would choose this over that, even if it's just a personal preference. And my justification is in functional MR, you need to symmetrically downsize the annulus. So you want to downsize the annulus symmetrically at all dimension. In degenerative MR, specifically in mitral valve prolapse, most of the dilatation happens in the posterior annulus because that is the part that dilates. The aortomitral curtain where the anterior leaflet is inserted does not dilate because that's fibrous tissue. So in my mind, there is no need to use a full ring and tackle that difficult area. And mind you, when you're doing mitral valve repair, putting annuloplasty stitches in that anterior annulus is the toughest part, because sometimes it is deep, exposure is not visualized. So, the idea is you want to downsize. And degenerative, the idea is not to downsize, but rather you want to stent and reinforce the annulus. So if anything, you either put the same size or you oversize. But in functional MR, the idea is you want to downsize the annulus. And that's why you need to put a full ring in all corners of the annulus.
Dr. Rakan.
Clear answer. Thank you.
Dr. Rakan, is the feeling of the needle going through the aortomitral curtain the same feeling as through the annulus?
Yes. I mean, Yes and no. So basically, you know when you're going through just muscle, which is endocardium in the left atrium, versus your needle going into fibrous tissue. Now, is it the aortomitral corridor or not? It's very difficult to make a distinction because in that area, there's actually no annulus. It's just a fibrous tissue throughout, extending from the aortic annulus down to the anterior mitral leaflet. So what you do is you want to keep your needle at that junctional point. Don't go very far and keep your needle pointed towards the LV, not towards the aorta. And because you increase the risk of capturing the aortic leaflet. As you see, if seen face vessel with me, every time I take a bite in the anterior annulus, I give cardioplegia in the, after I'm done putting all my my bites, my anchoring bites, I give cardioplegia in the aortic root. And that is specifically to test that I haven't caught the left coronary cusp with my needle. For degenerative MR, that whole risk is avoided because basically I use a band and there is no need for me to put a stitch in the anterior mitral annulus. Sometimes you're not, quite lucky to have bands. But, a lot of surgeons prefer rings for some reason or the other. And what I do in that situation, I'll take a wire cutter and fashion my own band. So cut the segment that I need to cut out from the ring, from the annuloplasty ring, and use it as a band instead of a full ring.
All right. If there are no more questions, I think we can have a 5-minute break before moving on to the next lecture. And Dr. Afnan Al-Malki will be taking over from now.
Assalamu alaikum. Good day. I think if we're ready, we can start with the second lecture. It's going to be presented by Abdulaziz, talking about minimally invasive mitral valve intervention. Abdulaziz, please, whenever you have time.
Can I start?
Yes, please, go ahead.
Okay. Good afternoon, everyone. Good afternoon, everybody. I'm Abdulaziz JMR for cardiac surgery. Today, I will speak about the minimally invasive mitral valve interventions. The introductions, minimally invasive mitral valve surgery does not refer to a single approach, but rather to a collection of new techniques and operation-specific technologies. These include enhanced visualization and instrumentation system, as well as modified perfusion methods, all directed toward minimizing the surgical trauma by reducing the incision size. The ideal mitral valve repair criteria, which include small non-rib spreading working incision, central antegrade cardiopulmonary perfusion, high definition modified 3D vision, tactile feedback, seal prosthesis attachment device, and minimal cardiopulmonary perfusion time, minimal cardiac arrest time, minimal blood products usage, and also minimal ventilation time, and incision pain and hospitalization. So the high quality requirement, which include greater than 95% repairs and few reoperation, less than 2%, and the operation mortality less than 1%, no SAM or residual leak. There is absolute and relative contraindication to the minimally invasive surgeries. The absolute contraindication, which is previous right thoracotomy, severe pulmonary dysfunction, mitral myocardial infarction, less than 30 days, coronary artery disease that is required coronary surgery, severe generalized vascular disease, symptomatic cardiovascular disease or stroke less than 30 days, right ventricular dysfunction, significant aortic stenosis or insufficiency, severe mitral annular calcification or significant bleeding disorder, or significant dilated aortic rod. On the other hand, the relative contraindication, which previous sternotomy, moderate pulmonary dysfunction, asymptomatic coronary disease, asymptomatic cerebrovascular disease, poor left ventricle function, the ejection fraction less than 50%, mild to moderate aortic stenosis or insufficiency, or moderate annular calcification. Evaluation of the minimally invasive mitral valve surgery. To perform the ideal cardiac valve operation, surgeon need to operate in restricted space through tiny incision, which required assisted vision and advanced instrumentation. Although the goal of a completely endoscopic mitral valve repair has not been widely achieved, and minimally invasive has continued utilizing a variety of techniques, including either limited incision, video assistant or video direct operation, or robotic techniques. The term minimally invasive or limited access cardiac surgery have suggested reduced size of incision, avoidance of sternotomy, and use of partial sternotomy or mini thoracotomy, or lack of a need of cardiopulmonary bypass. There are 4 levels of ascent in the minimally invasive cardiac surgery. We have 4 levels. Level 1 is direct vision, and there's a limited incision, which range from 10 to 12 centimeters. Level 2 is direct vision or video assist. This ranging from 4 to 6 centimeters. It's called a minimum incision.
And level 3, this is video directed and robotic assisting. This is called micro incision. This is 1.2 to 4 centimeter. And level 4, this is robotic, is less than the incision, less than 1.2 centimeter. Now we'll talk about the incision and the minimum mitral surgery. The type and size of the musculoskeletal incision remain central to discussion around the minimum invasive cardiac surgery. Myriad of modified small central, paracentral, and the mini thoracotomy incision are used to access the thoracic, the cardiac valve. Although many surgeons prefer the hemisternotomy approach, right mini thoracotomy yield excellent exposure for both direct vision and video scopic mitral valve access. To access the left atrium for direct vision using a limited access mini thoracotomy, 4 to 6 centimeter submemory incision is placed along the along the anterior axillary line. The small sections of the tragus and the intercostal muscle fiber are divided, and the thorax is entered through the fourth intercostal space with minimal rib distraction and no rib cutter. A small 3 to 5 centimeter incision with a minimal rib retraction can be used in video assist cases, and this is enough for prosthesis passage. Minimal rib spreading is to prevent the intercostal neck injury and used for intraoperative local anesthesia are the key to minimize the post-operative discomfort. This figure show in the right left side the hemisternotomy they use for the minimally invasive, and on the right side this is the mini thoracotomy. Both cases we use for the minimally invasive valve surgery. This is the cross clamp. We'll talk about the transthoracic clamping in the right minimum thoracotomy through the video access. Most superior and transseptal mitral valve approach through hemisternotomy require a large cardiac incision. And for aortic, mitral, and tricuspid valve operations, some surgeons use a hemithoracotomy extend to the fourth interspace with direct aortic arch and the right atrial cannulation. To access the mitral valve, they extend the aortotomy from the right atrium across the left atrial roof and continuing to divide the interarterial septum. Cannulation and cardiopulmonary perfusion. All the perfusion cannula are placed under the echocardiographer guidance using the sliding wire guide wire technique through a 2 cm oblique groin incision in both femoral vessels near to the femoral area. De-airing. The meticulous cardiac air removal is particularly important in the minimum invasive valve operation. Difficulty exists in the manipulating and de-airing the cardiac apex as it cannot be elevated. Also, with a right anterolateral mini thoracotomy, air tends to be tamed along the dorsal related ventricular septum and in the right pulmonary veins. Moreover, this position places the right coronary ostium in the most vulnerable position to interrupt air. Carbon dioxide inspiration has been particularly helpful in minimizing the intracardiac air and should be begin before the cardiac chamber are opened. Fusing the CO2 into the thorax and by to cross clamp release, the ventricle ventilate both lungs to draw the gas deep into the all pulmonary veins.
And after the urotomy closure and following cross clamp release, suction is applied through the aortic rod vent. Consistent transesophageal echo monitoring to essential to ensure the adequate air removal before weaning from the cardiopulmonary bypass. Aortic closure, occlusion, cross clamp for aortic occlusions, we use the transthoracic cross clamp, and some surgeons they are using the endoballoon for aortic occlusion. These are the transthoracic clamp for minimally invasive mitral valve operation. And this is the endoballoon aortic occlusions that insert through the femoral artery by the guide wire, echo guide wire retrograde to place to the ascending aorta. The right mini thoracotomy procedures. We have the right mini thoracotomy procedure. We have indication and contraindication. The indications is any mitral valve lesion, mitral stenosis or mitral valve regurgitation, any tricuspid valve disease, stenosis or regurgitation, and combined mitral and tricuspid. Some infective endocarditic cases, atrial fibrillation, ablations, AFib ablation procedure can be also be done as the only procedure performed, and patient with the secundum ASD and ASD brevium. Contraindication, avoid inpatient with moderate or severe aortic valve insufficiency as myocardial protection become challenging, resulting in the severe RV failure. Any patient with the fixed pulmonary hypertension or significantly high pulmonary pressure, patient with cardiac shock due to ruptured papillary muscle, patient with previous thoracic surgery or adhesion to the adhesion developed from the previous surgery or previous thoracic infection, and patient with severe MAC. So surgical step in the right mini thoracotomy procedure, double human tube and check position with the endoscope, central line, and position patient right side up, and the right axilla fully opened, and fem bypass through small right groin incision. This is the surgical steps. The surgeon now starting incision the pericardium. Then the cardioplegia insertion. The interatrial growth for more exposure the mitral valve. The trans clamp using the transthoracic. Now the exposing the mitral valve. the new cord loop technique. This is post mitral valve repair, and this is the 3-month post op. So communication and prevention. Retrograde cardiopulmonary perfusion techniques always induce a risk for atheroembolic stroke, vena cava injury, femoral artery complication, and the retrograde aortic dissection. Careful preoperative vascular screen can minimize these problems, and all the cannula should be inserted using the Slinger technique under echocardiography. So leg ischemia during the retrograde perfusion can be avoided. So with a significant decrease in the cannulated leg oxygen saturation, we place shunt from the cardiopulmonary bypass arterial cannula into the distal femoral artery, and the phrenic nerve injury can be caused by over strength stretching the pericardium, capillary term injury, or cryoablation or direct instrumental injury. The major problem in the patient with comprised pulmonary function, the injury can be avoided by visualization of the nerve using instrumental insertion and catheter usage. So the unilateral pulmonary edema is a serious complication and short perfusion time, system cooling, avoiding bar trauma, limited blood production transfusion, and minimize the lung deflation times can all reducing. So left ventricle dysfunction is a serious problem, and also can be avoided or minimized by selecting patient with ejection fraction or less than 40 to 50%. Ventricle distension is a serious problem and can be prevented by leaving a ventricle vent after the repair or replacement. The right ventricle dysfunction can be minimized. Meticulous cardiac de-airing before weaning from the cardiopulmonary bypass is essential, and the right 30% chest elevation place the right coronary artery ostium in perfect position for air embolism from residual left ventricle air or aortic entrapment during the cardioplegia infusion. The clinical outcome, a recent meta-analysis from the International Society of Minimally Invasive Cardiac Surgery showed that versus conventional and sternotomy minimally invasive surgery operation, the minimal invasive mitral operation has less post-operative atrial fibrillation, chest tube drainage, and transfusion and infection. There was no difference in the repair quality or freedom from reoperation. Moreover, operation mortality has not statistically difference, is 1.5% in conventional versus 1.2% in minimally invasive surgery. Other benefits include reducing the ICU time and length in the hospital, as well faster return to the normal activity. These advantages were despite significant longer perfusion and aortic cross clamp time. So they found more stroke 1.2 in minimum invasive, 2% in minimum invasive versus 1.2 in the conventional, and aortic dissection 0.2% in minimum invasive, and also a phrenic nerve injury 3% in minimum invasive comparing of conventional studies. This is our reference, our textbook, Lawrence. And thank you so much. And any question?
يعطيك العافية عبد العزيز. Just a note that for you, me, or the future presenters, if we have a video, please let's take our time trying to narrate what happens and the steps of the surgery to make it clear for everyone. So does anyone have a question to Abdul Aziz or the audience, please? Okay, so we're going to take 5 minutes break and we'll proceed with the third lecture. Thank you. Okay, so we're going to start with the third lecture for today with Dr. Ziad al-Sharif talking about outcomes of mitral valve repair. Ziad, if you're free, ready to go, please.
Okay, thank you, Doctor. Hello, everyone. My name is Ziad al-Sharif. I am R1 cardiac surgeon resident in University Medical Center in Riyadh. Today, I will talk about outcome of mitral valve repair. Inshallah. Our objective for today is I will start with introduction, then we'll move to repair rate, then in hospital mortality, then to degenerative mitral valve regurgitation as it is the most common. Then we'll talk about the advantage of mitral valve repair. Then we'll talk last about gender difference. As introduction, there is limited information on late outcomes of mitral valve repair, and several retrospective clinical and outcomes and study found that mitral valve repair improve survival. During the past decade, 2/3 of mitral valve repair is performed in asymptomatic or minimally symptomatic patient. And this is likely the cause in most large referral to centers. Mitral valve regurgitation is the most common valve disease in Western countries and is expected to increase. In this study, you can see that the sample size of the study, which is 18,147 patients, will be focused on mitral valve repair and its outcome. Here you can see the mean age is 66 plus minus 12, and 59% of the case is in males, and the mitral valve repair is represent 55% of all mitral valve surgery. Repair rate of all mitral valve surgery is 56%, and it is decreased with old age and female gender and high Charlson comorbidity index. It ranges from 65% in patients under age of 60 to 46% after 75 years old. And it is higher in male with 65% comparing to 43% in female. And it is 66% in patients with Charlson comorbidity index of 0, while it is lower as 39% in patients with index of 2 or more. In summary, old age and female gender and higher comorbidity index inversely associated with mitral valve repair. Hospital mortality increased with age as 3.4% in patients under age of 60, comparing to 10.3% at the age of 75 and more. It's also higher in patients who underwent replacement rather than the repair, and combined surgery rather than isolated surgery. The mean of ICU duration were 17 plus minus 15 days, and length of stay is 9 plus minus 12 days. The important thing to mention here that in hospital mortality of isolated mitral valve repair was only 1.1% versus 5.8% in isolated mitral valve replacement. In degenerative mitral regurgitation, which is the most common etiology, repair was significantly lower in patients who underwent combined versus isolated mitral valve surgery. And who underwent repair were younger and more frequently men and had lesser burden of comorbidities compared with replacement. Repair also decreased with increased burden of comorbidity as 77% in patients with Charlson comorbidity index of 0, compared to 59% in patients with comorbidity index 2 and more. And repair rate was also lower in women than in men, as 59% versus 80%. Although women were older and with higher comorbidity index. Here we can see that degenerative mitral valve regurgitation has a better 1-year rate of death or readmission for heart failure than secondary mitral regurgitation. And also isolated surgery has a better 1-year rate of death or readmission for heart failure than combined surgery. Here we can see that in hospital mortality, according to the type of the surgery and etiology, is better in degenerative type and in isolated than in isolated surgery. Here's some main result to summarize that mitral valve surgery associated with hospital mortality increases with age and Charlson Comorbidity Index, replacement surgery, combined surgery, and etiology. Degenerative mitral valve, the main etiology leading to mitral valve surgery, and it is twice as secondary mitral valve regurgitation. Operating mortality and 1-year rate of death and heart failure readmission were twice as high in second mitral regurgitation as in degenerative type. Elderly and women were less likely to undergo mitral valve repair. In contrast, most patients with secondary mitral regurgitation underwent mitral valve replacement. The advantage of mitral valve repair over replacement is well established. Mitral valve repair offer a lower operating mortality and a higher left ventricular ejection fraction, preservation, and a lower risk of stroke and infection, and the avoidance of anticoagulation, and overall a better long-term survival. Repair surgery rate also markedly decreased when a combined procedure was performed. When patient underwent combined surgery, usually they are older or presented at higher Charlson Comorbidity Index or more advanced disease. Whether this lower repair rate is related to surgeon preference or to anatomical difference could not be established. However, given the well-established benefit of repair versus replacement across all subset, repair should be chosen of technique when the anatomy is suitable. Imperial study have shown that women were underdiagnosed and undertreated and referred later than men for mitral valve surgery, which translated into excess mortality risk compared with men. Two potential explanations can be proposed. First, the anatomical difference, and second, the gender-based bias. Regardless the reason, the lower rate of repair in women is major concern deserving specific correcting action. In other study, we will review that out of 840 patients, there was 4 early mortality and 179 late mortality. The cause is mostly sudden death in addition to congestive heart failure, stroke, myocardial infarction, and anticoagulation-related hemorrhage. Here you can see that the leading cause of all-cause mortality in the study is COPD, while the leading cause for reoperation or recurrence is isolated anterior leaflet prolapse. In this study, long-term survival of patients with more advanced symptoms was below expected. The survival for general population match for age and sex, as shown in figure 4. These findings support the recommendation of early surgical intervention in patients with asymptomatic severe mitral regurgitation and normal left ventricular function. Here you can see that New York Heart Association class 4 was below the expected survival for the general population matched for age and sex, which is marked as a red dot. 38 patients underwent repeat mitral valve surgery. The indication was recurrent mitral regurg or mitral stenosis or endocarditis. Investigators compared the outcome of 127 patients who had mitral valve repair with 127 who treated conservatively, and found that surgery had a survival advantage on a symptomatic patient with a normal left ventricular ejection fraction. And surgery is also recommended for asymptomatic patient with impaired ventricular function, although mild left ventricular dysfunction is increase the risk of late cardiac mortality. The severity of mitral regurg play an important role in the development of adverse event. the severity of mitral valve play an important role in the development of adverse events such as congestive heart failure, AF, and cardiac death in asymptomatic patients with mitral regurgitation. As pulmonary hypertension also predict adverse event in asymptomatic patients with mitral regurgitation. The last thing I will talk about is that the patient who had mitral valve repair had a small but constant risk of thromboembolic event. The highest risk was during first year after surgery, justifying the recommendation of oral anticoagulation during the first 3 post-operative month, and probably should be extended to 6 months or longer. AF did not have an independent effect on survival after mitral valve repair. Infective endocarditis was rare in the study, and only 9 patients out of 840 developed this complication. Unlike heart valve replacement, which is associated with risk of infective endocarditis early on after surgery, there was not any single event during the first year follow-up in the study of mitral valve repair. There is my reference. Thank you for listening. If you have any question, please.
Thank you, Ziad. If anyone has a question, please proceed. Okay, I guess this is it. Thank you so much for attending. See you next time.